We have Dr. Mulligan joining us. Dr. Mulligan is an academic and specialist who has conducted research using sociological, epidemiological, legal, and surgical audit research methodologies. Her publications address a broad range of topics, including medical records privacy, lesbian well-being, quality improvement, risk management, and abortion methods. She was awarded the Ranscog Excellence in Women's Health Award in 2019. In her 20s, she worked on the establishment of women's community health centres. In her 30s, she generated evidence as to the safety of abortion. In her 40s, she orchestrated the introduction of mifepristone to South Australia. In her 50s, she developed surgical and ultrasound training materials. And more recently, she's been working with Professor Helen O'Connell on the development of anatomically accurate models of the clitoris. She's very active in the education space and has produced a number of teaching videos, one of which demonstrates teaching uterine evacuation to novice surgeons using fruit. This link was distributed as pre-reading and also will be posted in the chat. Please watch it if you haven't already. It's a very useful skill to learn. Today, Dr. Mulligan will be speaking on the topic, Induced Abortion is a Positive Pregnancy Outcome. Thank you, Dr. Mulligan.
So I'm delighted to be there with you today. I had a lot of fun at a PVOGS conference teaching 120 participants how to use a manual vacuum aspiration syringe on dragon fruit one year. And I would have liked to do that again this year, but we couldn't actually be with each other. So I'm just talking to you about, I guess it's a summary of some of the research that I've done over the years about abortion outcomes. And I think I really focused a lot on this because early in my career, there was a lot of talk about how dangerous abortion was, how alarming abortion was. People were quite frightened by the idea of abortion or the idea of a doctor that would be willing to do abortions. There was quite a bit of research that was presented as if it was evidence that abortion was harmful to women. There was research claiming that a history of abortion predisposed women to breast cancer, which just took years to put to bed. Finally, the College of Surgery and the College of ONG in America had to issue a joint statement to refute that one. And that really made me very interested in thinking about, well, what is the real evidence about the impact of abortion on women's health and more broadly? And because there's so much anxiety in sexual health, there's a lot of risk management. And of course, risk management really focuses on studying risk and mitigating risk and trying to evaluate what risks really are. And I tried to use the tools of risk management to try and evaluate the risks of the treatments that I was providing. And of course, there are real risks to women and to providers, which really have to do with their reputation. And I didn't quite realise how much this was the case until an anaesthetist that I'd worked with for a long time said, you know, I just don't understand why gynecologists are so reticent to provide abortions in South Australia. And he said, well, they're worried that it will get out that they're abortionists and that GPs will refuse to refer patients to them. So those kinds of concerns led me to really do quite a bit of research about what the evidence is. And also I worked with, oops, we've got to go back a slide. I worked with a doctor called Dennis Chambers, and he told me about an experience in his early working life. He was a GP at Clare in South Australia, and he was a GP surgeon back in a time when GP surgeons would do appendectomies, cholecystectomies, caesareans at the local hospital. And he told me about a time in the 1960s when one of the nurses that he worked with at the hospital approached him and said that she was pregnant and that she really felt she couldn't continue the pregnancy, and asked him if he would provide an abortion. And he said, no, abortion is not lawful in South Australia and I can't do that for you. And the very next day she went out and drove her car into a tree and died. And Dennis was greatly affected by this. He never said no again. He provided abortions from then on, and he joined the campaign for law reform. And he was the one who really explained to me, by telling me that story, one, that abortion can be life-saving surgery, and two, that it's possible for a doctor to have a conscientious commitment to providing abortions. So I looked at the outcomes and the sources of data that would tell me something about what the outcomes really are. And of course, the maternal mortality rate and data about women dying is quite widely collected around the world. And so the relative risks of continuing a pregnancy or to term or stopping the pregnancy at some point are quite well understood. There's also quite a lot of impacts of women being able to exercise autonomy and self-determination, which really impact on the quality of adult relationships. And there's also quite a bit of research about the outcomes for children. There have been a very big set of studies called the Turnaway studies, where researchers followed women who had sought abortions and been refused in 5 different countries, one of which was the United States, and looked at what happened to them after that, and what happened to the children, and what happened to the other siblings in the family. And it's really the only intervention that's available that's a primary prevention for child abuse, neglect, and raising children in poverty. There are also some quite broad public health outcomes, some of which have been described by economists. And the ability to plan your life and use family planning methods really has a big impact on women's ability to participate in society and have jobs and be doctors and things like that, as well as, because abortion's practiced selectively, there's a predominance of abortion of higher risk pregnancies, and ultimately that has an impact on the number of dependent children and adults in the whole community. And of course, there are global health outcomes. That is, the world population is really changing quickly at the moment, and the ability of women to regulate their fertility has a really big impact on things like climate change and all of our futures. So I'm going to talk a bit about each of those sources of data. Because there are a lot of women in the world, and there are a lot of pregnancies happening, and there are a lot of abortions being done, and many countries collect very accurate data about death, there's some really quite large data collections, and the Food and Drug Administration in the United States published on the mortality outcomes after the first 1.5 million medical abortions in America. And that's how we know that the death rate's about 1 in 100,000. And I think the really interesting thing about mortality data is wondering or considering what's the appropriate comparator. You know, is that a good result or a bad result? Is that a positive pregnancy outcome or an adverse outcome? And it's hard to know what to compare it to, but you know, fit young women do drop dead every year in Australia who are on the combined oral contraceptive pill, and there have been some very large studies in Europe involving 1 million woman user years, which indicate that women are, in return for being able to control their fertility, women are willing to accept some risk. In fact, it might be more dangerous to take the pill for a year than to have an abortion. And because the death rate from abortion is so small in Australia, it's really impossible to work out what the rate is. I mean, there hasn't been a death in South Australia since the 1970s. However, in bigger populations like the United States, there are bigger data collections, and you can make some kind of comparison between the risks of surgical abortion, medical abortion, spontaneous miscarriage, or delivery at term. And it's quite clear that continuing a pregnancy to term and having a baby confers risks that are at least an order of magnitude greater than stopping the pregnancy at any point. And I like to show this data. It's quite old, but Romania was a country which was good enough to keep really good maternal mortality statistics during a time when they conducted a legal social experiment. So there was a time when abortion was lawful in Romania. And then they got a new government, the Ceausescu regime. It was a military dictatorship. And that government's stated aim was to have more people in the army. And so they decided to make abortion unlawful so that women would have more children and there'd be more people available for the army. And then at a later date, that regime fell. If you were watching the news in the 1980s, you might have seen there was a big uprising and Ceausescu and his wife were shot, and a new government got in which made abortion lawful again. And you can see what happened to the maternal mortality rate and the deaths from unsafe abortion, because of course women didn't stop having abortions. They just couldn't get them from doctors and hospitals, and it was a clandestine operation. So in South Australia, we only did half of that experiment in 1970. Before 1970, abortion was not lawful, and a woman a month used to die in South Australia. And after 1970, it became lawful, and I think there's been one death since then, and we got a fall in the maternal mortality rate quite similar to that. And I have to apologise for the amount of data slide, but I like to show it because it sort of gives you a global overview of relative risks. So this is one part of a huge epidemiological study, the Global Burden of Disease Study, which this slide collates the data from the top 9 causes of maternal mortality in the world over quite a long period of time. The x-axis is proportion, so that's not the number of millions of women who died, it's the fraction of women who died. And along the y-axis are the World Health Organization regions. And the light blue part down the bottom there is all the women who died from unsafe abortion. And it's about 13% of maternal mortality globally. And Australia and New Zealand, there are no deaths from abortion, but Australasia is a region that also contains New Guinea, where there are a lot of deaths from a lot of reasons. And the reason why I wanted to show you this slide is really to discuss relative risk and say, women who have unsafe abortions and run these terrible risks and some of them die from the abortions that they've attempted, are weighing up the relative risk, aren't they? They're really saying the risks of motherhood are so terrible and fearful and frightening that they'd rather run this other risk down the bottom here. The other thing that's quite interesting about this is that to address some of these risks for those countries that are trying to bring down their maternal mortality rate and achieve their world development goals, in order to address these and reduce these causes of maternal mortality are really quite expensive. So to stop women from dying from hemorrhage, you really need blood transfusion services. And to address PPE and obstructed labour, you need labour and delivery suites and trained obstetricians. But to reduce the mortality from unsafe abortion, all you have to do is provide safe abortion. And if you provide contraception to your population, they don't even get on this chart at all. So some countries that don't have very much money and are trying to bring down their maternal mortality rate, like Cambodia and Nepal, really made a public health decision that they would act first to provide safe abortion and contraception to their populations. And another illustration of the reason why abortion is life-saving surgery is, I just put in this set of slides, which I'm just going to show you quickly. This is a young woman who had 2 abortions in Liberia before she moved to South Australia. And when she was being investigated for dysmenorrhea, this CT scan was done, and I don't have a pointer, but if you can see where her uterus is, you can see a white plastic catheter arising above it and going up her abdominal cavity. And looping over her liver. And this was removed. The surgical team went to her and said, you know, we found this thing, this big. And she was not all that surprised. She said, oh yes, there was no anesthetic. I was awake when that was put in. And she said, well, I'm glad I had it done though. It was life-saving surgery at the time. If I had have had a baby at that time, my parents would have killed me and probably the baby too. So she was prepared to confront the risks of this procedure in order to save her own life at that time. Of course, she was very happy to now move to Australia where she can get real health care from properly qualified doctors. So the mortality of motherhood is quite high compared to the mortality risks of having an abortion. And as the maternal mortality definitions have changed, that's become even more true. So in recent years, deaths that occur after delivery are also included in the maternal mortality rates in some countries like Australia, and deaths from domestic violence and self-harm have started to be included. And the risk of mortality for women in fertile age groups from being killed is greater than the risks of labour and delivery. And the comorbidities of motherhood are really quite significant. And the financial disadvantages of motherhood are another thing which women often seek to avoid by having an abortion. So if a woman thinks she's going to lose her job because she got pregnant, she may choose abortion. And certainly it's well understood in Australia that one of the reasons why the fastest growing group of homeless people in Australia are women over 50 who've come towards the end of their working lives. They've had interrupted work, they haven't got any super, they're living in poverty, and they can't afford the rent. So these are the sorts of risks that women are weighing up in their mind when they're trying to decide whether to have an abortion or not. There's also quite a bit of research about the association between abortion and domestic violence. And it's quite clear from the Australian Longitudinal Women's Health Study, which is a big study of 40,000 Australian women that went for 20 years and started with cohorts of women who were 20, 40 and 60. So by the end of it, they'd covered women from the ages of 20 to 80 in Australia. And where women have less autonomy and control over their lives and selves, they have more pregnancies, more miscarriages, more abortions, and poorer perinatal outcomes generally. And that's observed all over the world. I think another thing about abortion is that it has a lot of social consequences for women who don't have abortions or for adult relationships generally. That is, when women don't have to be afraid that they might fall pregnant or that someone might find out that they've been having sex because they get pregnant and it becomes clear to everyone, it means that they can focus a lot more on the quality of the relationship. And I think that as fertility control methods have become more available and accepted in Australian society, and also with the IVF program, as the link between sex and procreation has really been separated, that has allowed people to really think more about the quality of relationships and what sexuality really is about. And I think that's why it wasn't until this century that Helen O'Connell has actually published on what is the anatomy of the clitoris. And it was only when she did that that I looked in my anatomy textbook that I studied from and saw that the clitoris had been deleted. I do remember in the 1970s looking through my Harrison's anatomy and going, why are there 5 pages of dissections of penises in here? And there's one picture of a perineum and just the glands as a little dot. But I can't say that I paused to think about the underlying philosophy of the medical profession or why that would have been the case at the time. I just got on with my studies. But I have come back to think about that more recently. And there's also much more emphasis on consent in the 21st century than there was in the 20th century. There's less acceptance of coercive relationships. There was a long campaign in South Australia to get rape within marriage recognised. It wasn't until the mid-1980s that up until then, a woman's only opportunity to consent was when she said, I do. After that, in law, she was assumed to be consenting ever after, and there was no such thing as rape in marriage. And of course, we had the Reclaim the Night movement saying, you know, women demand the right to walk the street at night without fear. That women started to insist on freedom of movement. So these things are emergent, and as women gain more control over their lives and sex and relationships and whether to bear children or not, many women aspire to raise only one child or none. And the Institute of Family Studies have done some work which suggests that a quarter of all Australians will go to their grave never having had a child now. The most common household size is one. The possibility of adult relationships without children is much more accepted. And women channel some of their creative energy into having careers or being doctors or being engaged in public life. So overall, there are fewer children and more little old ladies like me. And it's become very clear that fertility is very responsive to social forces. So I don't have a pointer, but if you start at that graph on the left, you can see the impact of the Great Depression, the Second World War. Women went into the workforce, men went away to war, then they came home, women got kicked out of the workforce. There was the post-war baby boom and economic boom. And then you can see that big drop. That's the oral contraceptive pill becoming widely available in Australia, and that was in the 1960s. And we went about as far as we could with fertility control with that. It's not 100% effective, and it's not all that easy to get, or it wasn't when it first arrived. And then abortion became lawful in the 70s, and you can see that other big drop. And fertility fell below replacement in 1976 and hasn't been above since, although you can see a little blip up there when the baby bonus came in. There's also been quite a bit of research about the impact of abortion on children's outcomes. I'm old enough to remember when Bob Hawke said, by the year 2000, no Australian child will be living in poverty. And it turned out that by the year 2000, that was just an aspirational goal and wasn't really achieved. But I think there are a lot of Australian women who really agree with that aspiration. And if they're living in poverty, or they foresee raising a child in poverty, like on a single parent benefit, or if they're already raising children in poverty and they don't want to add one more, they will choose abortion. Also, we have antenatal screening, and there's selective uptake of abortion based on the result of antenatal screening programs. Not everyone discovers that there is a problem with their pregnancy will choose abortion, but they are more likely to. And one of the impacts has been that adoption pretty much evaporated and the orphanages closed. There used to, when I was a medical student going on community placements, they sent me out to St. Joseph's Home for a day, which was a wash house where young pregnant women who were not married would be sent by their families to complete their pregnancy, and then they would give up their children for adoption when they were born. And there's quite a good big screen movie called Philomena with Judi Dench, which depicts a very similar institution in Ireland. Anyway, they've all shut now. The global turnaway studies found that the problems that women predicted with motherhood were borne out. So women who were worried that they would be living in poverty, lose their job, that they wouldn't have enough to raise their other children. Turns out they were quite right. And the turnaway studies have found that women were impoverished after an unwanted child was born, and that other children in the family were delayed in reaching their developmental milestones, as well as the unwanted child. And of course, because pregnancy is very common and abortion is very common, these very individual decisions that women make translate into very broad-based public health outcomes. So There are a couple of pieces of epidemiological research which show that in populations where antenatal screening is available and abortion is available, that the proportion of babies born with significant congenital abnormalities is quite a bit lower. The Freakonomics economists have claimed that the falling crime rate in New York City is related to the availability of abortion, and it was quite scandalous when they first published that article, and I thought it was ridiculous actually, but I have actually been to New York City, and if you understand just how difficult the circumstances in New York City are for young pregnant women with no money, it actually becomes a bit more plausible. I did meet a midwife who, during the AIDS epidemic, was working in a foundling home in New York City. They had 80 babies there that had been abandoned by their mothers in public hospitals after birth because their mothers were HIV positive and had nowhere to take the baby home to. So when I met her and heard that story, I mean, there was no institution like that in Australia. We actually have got more social services here. So whether the Freakonomics thesis is right or not, it certainly is clear that when there are fewer children in a society, more can be invested in each child, both by their family and in terms of public health, education, immunisation, child protection services, pool fencing. The fewer children that you have a better opportunity for a better life. And of course, that pattern of fertility that I showed you for Australia is playing out in many different countries in the world. The fertility rate is crashing. It's down to 2.5 babies per woman, and we think when it goes below 2.2 that's actually going to be below replacement, and the world population is going to start shrinking. Takes a while, there's a lag, because of course a baby born now is probably going to live for 80 or 90 years, so it'll be a while. But as more and more girls are going to school and more women have got access to healthcare like abortion and contraception, there are fewer children being born. So we're expecting that the global population will stop growing and then shrink, but of course, where is it going to peak? Maybe 10 or 11 billion people. And we don't know whether it's going to be possible to feed, house, clothe and provide healthcare to 10 or 11 billion people without completely wrecking everything. But you're going to find out. You people who are now planning your medical careers are going to be conducting your careers while all this is happening. And, you know, medical practitioners are very practical people, and they're busy thinking about what to do about all this. And some of them are joining Doctors for the Environment or Extinction Rebellion, or running parties like the Greens, or being involved in Get Up, or engaging in more individual pursuits like trying to get their super out of fossil fuel investments, recycling their garbage, putting solar panels on their roofs. But of course, anything that you do in your professional career which supports women's self-determination, like supporting the Royal College of Surgeons' Respect campaign against bullying in operating theatres, ultimately is going to make more room for the global population to stabilise. And of course, just providing abortion contraception is very facilitating. So the best health outcomes on an individual level for children, at a public health level, and for the planet occur when everyone has access to effective contraception. Women can get abortions if they want them. Women who don't want abortions are not forced to have them. And this is really about domestic violence and controlling relationships and reproductive coercion, isn't it? And everyone can find a non-judgmental doctor who's willing to actually provide them with healthcare. And I'm shameless. I'm here recruiting. I'm really hoping that some of you are going to be interested in joining the teams that are required to provide these services to the population wherever you are going to be practicing. Because to provide those services to everyone universally is a big job. We need lots of pairs of hands. You don't need to be an abortion provider to help with these things. You can work on domestic violence. You can just be a supportive doctor who responds to requests from your patients. That's enough to make some of these things happen. I just put this in for you to look at while I'm waiting to hear about questions, but this is an anaesthetist who's glued herself to a bridge in London during the Spring Rebellion. She's part of the Extinction Rebellion actions. And I don't really think that you're all going to go out and stop traffic, but I am very hopeful that because you're at a point where you're planning your careers and forming your own professional values, that you'll see a value in providing contraception or referring for abortions, because that's how we're going to get the best outcomes.
Great. Thank you so much, Dr. Mulligan. I think everyone would agree that you've been at the frontier of your work over the last, or your whole career, essentially. We really appreciate the work that you do, and I hope that some of the other attendees today have been inspired by what you've told us. One of the questions we have today has been, do you think that the current COVID-19 situation has negatively impacted access to abortion services, both in Australia and also around the world?
Oh, well, I think it's had mixed impact. I think Dr. Rochel already spoke about what the college is doing and recognition that, you know, a lot of women are now locked down in a house with someone who's coercive and violent, and that is probably not good for their mental health, but it will probably result in unwanted pregnancies as well. But it's interesting. I understand that in New Zealand, the new, more relaxed abortion legislation was proclaimed the day before COVID-19 restrictions came in. So abortion providers in New Zealand had already been working out how to provide access to early medical abortion, and they've just gone straight to telehealth, not requiring anti-D testing or an ultrasound, mailing out medications. Really, they took it as an opportunity to make a great leap forward in access. So that's possible. The college was very decisive in making a statement about that it would really be safer for women to be able to access early medical abortion remotely without as much testing than to be coming into clinics. So it's not all bad, but yes, I don't know what to say about that. I mean, there's a struggle about whether women can be allowed to make decisions about these things going on all over the world, and it's sort of stuck at a different place depending where you are. And the place we're at in Australia is, there is access, but it's controversial.
And for those people who are really interested in getting involved in family planning, do you have any way you can direct them how they can get more involved?
Oh, well, I think Family Planning are the lead organisation providing education for health professionals in Australia, and they provide a lot of information and support. So I'd recommend getting involved in their programs if anyone's interested. I mean, it's not neurosurgery. None of these interventions are very difficult, and they're all within the capabilities of all the people who are watching this. It's not hard. You just have to decide whether you want to do it or not.
Absolutely, and we'll share the link again to that video. I would strongly encourage everybody to watch it. Thank you, Dr. Mulligan, again.